Good evening, everybody. I'm Isabel Bogdan, and today I am going to bring our second event in our Conversations in Health and Humanities series. This is a wonderful series that highlights the advancing of women's health, of evidence, equity, and empowerment. And I'll tell you a little bit about myself. My first name is Bertha Isabel Bogdan. I'm a women's health nurse practitioner. I'm alumna and an alumni board member of Columbia Nursing. I am also an employee and nurse practitioner at Columbia University, and I work for the Fazzolari Women's Health Integrated Women's Health Program, and I am the founder of Believe Women's Health. And looking at all of this, we all know that the landscape of women's health is vast. There is so much advancement, so much information that's coming at us with regards to clinical care, research, technology, public health, and policy. And yet, we have so many questions that we have to answer. Number one is, how do we listen to women? How do we honor their lived experiences? And how do we build systems that support women and their well-being across the lifespan? Today's conversation brings together accomplished panel of alumni and faculty leaders, and their journeys are going to help us to reflect and answer some of these timely questions. And this is a conversation. We welcome you to ask us any questions. We welcome you to wait until the end, or you can add them in the chat. But we want this to be an interactive conversation amongst the panelists. With that said, we're going to go through our conversation. Feel free, like I said, to ask us anything. Let's begin with brief introductions to give our audience a quick overview of the panelists' past experience and your current work. And we're gonna begin with Molly Finkel, Ida Sani.
Hi, good evening. I'm Molly. I am the Senior Director of Nursing for the Mount Sinai Health System, the Division of GYN Oncology. I joined Mount Sinai in 2015 and have been in a leadership and dual NP role since. I graduated from Columbia School of Nursing in the ETP program in 2011 and then completed my women's health master's in 2012 with a subspecialty in oncology, and then later went on to complete my board certification in oncology in 2015. So I do have a dual role in both leadership and a clinic, and I'm happy to tell you all about it as we get into it.
That's beautiful. Thank you, Molly. Veronica, you're next.
Hi, I'm Veronica Barcelona. I'm a nurse epidemiologist and assistant professor at Columbia University School of Nursing. I've been at Columbia for 5 years, and my program of research examines how racism, discrimination, and stigma contribute to maternal health disparities in the US. One of my ongoing studies uses machine learning methods to identify stigmatizing language documented by clinicians in the electronic health records of birthing people. We've identified types of stigmatizing language, who it is applied to, and that it is associated with pregnancy-related morbidities. These data are informing education and outreach to clinicians and hospital systems to identify why we are using this type of language and how to change policies and structures that reinforce bias, decrease empathy, and result in poor outcomes. And my vision is that all women will welcome their baby in an environment of respect, care, and love.
Thank you, Veronica. Jennifer Dorn.
Hello, good evening, and it's a pleasure to be on this panel with wonderful practitioners. I hope that we get a lot of interesting questions from you. I am a nurse midwife, women's health nurse practitioner. Until January 1st, I was a professor and assistant dean of the Office of Global Initiatives and director of our WHO PAHO Collaborating Center for Advanced Practice Nursing. I've I'm an alumni now and will have a different role at Columbia. One of the things I've done, my life has been dedicated to working with birthing families with the framework of equity and that maternal health is a human right. I was honored to be director of midwifery services in the South Bronx and open a community-based midwifery providing center for women out of hospital, primarily women of color, Black women, Latino women who had been excluded from the healthcare system, which operated for 20 years and defied all statistics on what should happen. I became director of the midwifery program here and also became project director for the U.S. PEPFAR ICAP Nurse Capacity Building Program, which ran from 2009 to 2016 to provide nursing, midwifery education, and HIV-directed services in 10 countries in sub-Saharan Africa. And I have been back at the School of Nursing building a global student clinical program for students in their last accelerated piece to spend the practicum looking at working with nurses and midwives, primarily in global South countries, so that they would really graduate with the sense of disparity, how to address it, and equity for people. So we'll stop there.
Thank you, Jennifer, so much. And Rebecca Schnall.
Hi, I'm Rebecca Schnall. I'm a professor of nursing and also have a joint appointment in the Mailman School of Public Health. In addition, I'm the Associate Dean for Faculty Development in the School of Nursing. And my work has largely been focused as a nurse scientist. Again, graduated with my PhD from Columbia Nursing, and I work as an informatician who focuses on leveraging digital health and artificial intelligence, AI, to improve outcomes for populations that have historically been excluded from innovation, particularly women, adolescents, and sexual and gender minorities. For the past 20 years, I've led over a dozen national clinical trials and longitudinal cohort studies that use mobile health platforms to expand access to HIV prevention, testing, and care. And much of my work has been grounded in community partnerships. Today, my focus is on building sustainable research infrastructure that supports community-engaged digital innovation, strengthens the prevention and health promotion workforce, and ensures that advances in AI and other technology are implemented responsibly and equitably. I see nursing as uniquely positioned to design the future of care and create a more responsive reality for women's lives.
I love everything that we are all bringing to women in this generation. And the next conversation we're going to be having is on the landscape in women's health. And the question here is to address, where do you see the most energy or urgency right now in your area of women's health, whether it's clinically or in research or in policy? So for a minute, let's just deep dive into that question, because as you see, we're all in different landscapes, but I just can't wait to hear how rich everybody's response is going to be. And we're going to begin with Molly. And if you need me to repeat the question, I'll be more than happy to do that.
It's a great question, and there's 4 areas that I see that are very much interconnected. The first one being in prevention strategies for our BRCA and mutation carrier patients. We now know that most high-grade serous ovarian cancers originate in the fallopian tubes, not actually the ovaries, which was a major paradigm shift that was discovered in 2001, and it's really transformed our approach to prevention. We now recommend staged surgeries with a salpingectomy or removal of fallopian tubes first, and then a delayed oophorectomy, removal of the ovaries later on when patients are ready. And this has led to an 80% reduction in ovarian cancer in our BRCA patients and about a 50 to 75% reduction in the general population. And now the Society of Gynecologic Oncology and ACOG recommend opportunistic salpingectomy at the time of any planned abdominal surgery. We also have seen amazing innovations in fertility integration with pre-implantation genetic testing that allows families to break the cycle of hereditary cancers. We can identify embryos without mutations and effectively eradicate these carrier mutations from family lines. And I'm sure we're all going to highlight this at some point tonight, but menopause is finally getting some very serious attention. Yeah, cheers to that. And we have much better data on HRT safety and hormonal management for very specific cancer types and staging, and dedicated menopause centers are emerging across the country to focus on sexual health and intimacy. And this gives our cancer survivors a much better quality of life and helps to support their sexual health and intimacy goals. And then lastly, our genomic sequencing of tumors, which has just blown apart the field of GYN oncology, where we're testing the actual tumor itself. And this has allowed for incredible biomarker identification and expansion of targeted treatments with immunotherapy, antibody drug conjugates, and a host of new FDA approvals in recent years.
Oh my gosh, thank you so much. That was so good and so relevant, right? I mean, what is not being given to the population right now that we're in the midst of, I just can't wait for it to become such a breakthrough. Thank you for that, Molly.
Sure.
And Veronica Barcelona, if you need me to repeat the question, I can. Let us know what you're thinking with regards to the landscape in women's health.
Sure. So for me as a nurse scientist, I think the most urgent area looking at maternal health disparities is, of course, the issue of racism, bias, and stigma. So a recent report was published by the CDC last year, and it reviewed contributors to over 900 maternal deaths. And they found that a third of women had stigma or bias as a contributing factor to their deaths. And this is important, I think, as an additional 80% of all maternal deaths are preventable. So my work really focuses on how can we identify how stigma and bias is being operationalized by clinicians, by individuals, and by systems to result in poorer care. So this, we talk about stigmatizing language and language as language that's documented by clinician, written language, verbal language, and also behaviors. And so in my recent study, we found that women that had stigmatizing language documented were more likely to have chorioamnionitis, an infection in pregnancy. They were also more likely to have a postpartum hemorrhage, and they were more likely to have a low-risk cesarean birth. So these are some really actionable results that we can use to talk to clinicians and work with health systems to use stigmatizing language as a marker for bias, and then to have discussions and change really the culture in the unit, in the hospitals, to change that and hopefully reduce morbidity and mortality.
That is so special. And you're making me think of a childhood rhyme of sticks and stones can break my bones, but words can hurt me. And the level of respect that is due to our patients and the language that we're using is evidence of we need to do better, right? Just with the words that we're using. So thank you for that amazing work. And Jennifer Dorn, let me know if you would like to have me repeat the question, but I'm not sure if you need me to do that.
No, and it's I'm actually was thinking of many of the things Veronica just said, so I'll just segue into it. My work has really been from being a clinician, a nursing midwifery educator, policy developer, and researcher. So it's kind of had a multi-level focus. I just finished, so I think the real crisis in terms of maternity care, when I say that, I mean birthing people. I think it's always important to say that, so we're really inclusive. And historically, it has been women. We don't want to forget the history of sexism and where women are. And I think we're into a very important era of really expansion and inclusion. This past year, I worked with WHO on a new document, which is called Transformative Models of Midwifery Care. And I think this is really important because we're escalating in terms of disparity of maternal health. So we're not closing the gap, it's escalating. And particularly in the last, under this current period in the United States, I think we've been fighting against the racialization of maternal health care and all of healthcare, and instead it's being exacerbated. So a Black woman has 2.5 times higher rate of death than a white woman in this country. And we can't ignore that. It has to be, we have to have, in my opinion, a public health in community approach that begins with accessible care, midwifery led, and will lead up into a system. We have one of the highest rates of cesarean sections in the world, and this is not the solution. We need them, access to them to be life-saving, but we have to go back to the public health approach in the community. And in terms of global health, global South countries, a woman who is pregnant has a 130 times higher chance of death. I mean, what is wrong? What are we doing? And now there's no USAID. It's been drastically cut. So the countries that I work with and learn from nurses and midwives are facing unimaginable challenges to improve maternal health. One of the reasons that we have the student program at Columbia, at the School of Nursing for the MDE students, is to really have students immerse themselves and see what do nurses and midwives do, and particularly in global South countries. How do they deal with this day by day? How do they get energy? How are they innovative? And I think it's one of the places we can open. So I'm looking at all the levels. We're working on building midwifery programs in several of the countries that will have master's programs. There's many pieces that can fit together, and I think that need to be done urgently. And I think documenting women's voices is very important. I did a book at the Birthing Center, which did oral histories of women that birthed there to try and see what they most learned and wanted. And one was to have voices in policy, voices in control. I also conducted with other nurses and midwives a oral history project in Sierra Leone and Liberia during Ebola. And then about how they survived and what did they want at policy level. And as we were analyzing this, COVID happened. So then we extended it to do oral histories of nurses working at New York Presbyterian in their experience in a pandemic. There's so many levels that we can get information, and they all point to nurses and midwives have to have higher roles in policy. We're equipped to, and we need it.
Thank you, Jennifer. And this boils down to helping patients tell their story of championing life. So, Rebecca Schnall, tell us what the landscape in women's health means to you.
So the landscape in women's health, I'm encouraged by my earlier panelists and what they were describing, because I think there's challenges that persist. It has been described really articulately by Drs. Dorn and Dr. Barcelona, but I think part A is identifying the problem, and especially I think as a researcher's lens, once we are able to do that, and so I think this recognition of what some of these challenges are, and at the same time, concurrently, really welcoming and embracing that there are new technologies that are available that we never thought would be imaginable. I think what Molly was describing, those are amazing findings that we have. And I think it's for us, it's really thinking about designing systems that women can realistically navigate within the constraints of their daily lives. And so much of my work is focused on understanding the community and the community's needs, and what are these structural barriers that include things like transportation, childcare, stigma, workforce shortages, education, literacy, health literacy, and that really continues to shape the outcomes, even in the face of these powerful clinical interventions and technologies that we're discovering. And so I think it is both this identification of these technologies, but the integration with behavioral science, informatics, and then finally, really community partnership that moves us from designing these interventions and finding these fabulous technologies, but then moving them towards really community-informed tools where women can access this technology and these other innovations so that it can help improve their outcomes.
I love that. And you're bringing us into the next question that we're going to be answering. This has to do with models of care, innovation, and access. And Dr. Schnall, when I think of your work in nursing, it's always hindsight is 2020. And I don't know how you're able to look into the problem and you stand back and you look at the bigger picture. So this is the question that I'm going to ask you now. We're seeing new models of care emerge across women's health, from survivorship programs to midwifery models to integrative and community-based care. What innovations are you seeing that are improving access or changing the patient experience?
Okay. So thank you for the question. And as you said, I do find this to be energizing and this has really what has informed my research and what I hope to see implemented in clinical care. And so I think of things that extend care beyond the traditional clinical walls. And so it's not the delivery that we deliver right at the patient bedside, quote unquote, but it's how people can use these tools in their everyday lives, whether it's to self-manage whatever their well-being is, or if they have a health condition, but also being able to access healthcare and healthcare tools that they otherwise wouldn't be able to, right? Thinking about those barriers that we talked about earlier. And so one example is we have a national longitudinal cohort study in women who are self-testing for sexually transmitted infections and HIV. And so this is an opportunity for women who we've met now and enrolled over nearly 2,000 women who otherwise aren't going to providers, go get tested for sexually transmitted infections that they're at very high risk for. And we're bringing it to their home so that women can really self-test and embrace and engage in their own healthcare. So I think some of these tools, whether it's point of care testing, mobile health tools, and other types of technology, really have the potential to shift our model of care that we deliver right now.
Thank you. Our next panelist, I'm going to be skipping around. Dr. Barcelona, I'm going to ask you for your second opinion on this one.
Okay, so this is about models of care.
Yes.
So I agree with Dr. Dorn that we really need to move towards a community and midwifery-based model of maternal health care in this country if we want to improve outcomes. And within the hospital, because about 98% of women and birthing people give birth in hospitals in the US, I think there's a lot we can do to change healthcare delivery away from a medical and fear and pathology-based approach to a more patient-centered approach. And really, I think a lot of the work that I do, I use all kinds of fancy methods, machine learning, epigenomics, and in the end, the message is to listen to women and to center women in their care. So there's so much we can do. We know what works in other countries and in other locations, and even in the US in birth centers that are midwifery run. So to me, that's the biggest change that we can make to improve delivery of maternal health care services.
I agree. We're the matriarchs. Dr. Dorn.
Well, I think I'm still going to say no matter how hard this is, we have to keep finding for public health models in the community. In the United States, yes, it's all centered in hospitals, but I refuse to give up that is going to be the best form for the future. And now public health has been even more taken apart in this country, with basic vaccinations being challenged. So it's a really critical time to still carry the models of what can get taken out to the community. Because if we listen to the women, we need to go into the community. It's just different in the hospital. I've been working with the Bronx Borough President, Vanessa Gibson, who's actually trying to open a birthing center again and helped write a report. And the idea is really start to decentralize. So I'm arguing that we don't forget public health and we take it out because I'm not arguing against anything anyone's saying. I'm just saying let's keep remembering that we need a shift for away from healthcare for profit and back into being accessible to all. And one of the things about working so much globally in Global South is that I feel like some of the technologies that we have here need to really be shared there. And I think I've always felt a dilemma being a clinician and an educator about how could I ever do research and now how can I ever learn these other technologies, which I'm plodding along at because I know that's the future. How do we make this accessible to nursing educators? And how do we make it accessible to clinicians? I think it's a real challenge to focus on how that goes from to Global South nursing and midwifery leadership to empower them and break out of it could be a further divide in who has access. And I do think, Rebecca, just to say, you've been pioneering in doing that. So much of your work has been about making that accessible. And I feel that's really important model for researchers to make sure that I've looked at so many grants in the last few years that I was supposed to give permission to or not, and it was exchanged between one global north country and another global north country. And that's not okay. It's just that knowledge has to be broken down. Oh, I see someone's raising for the birthing center in the Bronx. Anyway, we have to really be conscious about this. And that's why maybe some of us sound like we're just harping on the same thing, but it's critical. This divide is increasing right now, not getting smaller.
I agree. And, there's so much that we have with regards to technology that still has yet to be implemented, right? Molly, you're next. Let me know if you need me to repeat the question.
No, I agree with my colleagues. We could have the most advanced science in the world, but if we don't have education and access to it, it's irrelevant. So I do think there have been some amazing innovations, though, just to sort of shadow what my colleagues have said. But something like Nurse Navigators, which was approved by CMS for payer support in 2004, which is an incredible role for patients in a cancer center, creates sustainable funding and guided pathways for patients navigating their care systems and their diagnosis. The navigators connect patients to all kinds of resources, including copay assistance, free drug programs, clinical trial research teams. So it's a crucial role that's improving access. But despite all of that, we do have low clinical trial enrollment of our minority patients and underrepresented populations. This is slowly improving through outreach and translated materials and addressing practical barriers, but it's still an ongoing concern. Diverse enrollment is both an equity issue and a scientific imperative, so we really do need to work on that. But something like HPV home testing and virtual platforms for counseling. HRSA's Women's Preventative Services Guidelines were updated just January 5th of this year to explicitly include patient-collected high-risk HPV testing for women of average risk between the ages of 30 and 65. And the American Cancer Society also updated its guidance to include the self-collection as an option. So those are amazing improvements, but we still have work to do.
I'm so glad you were like reading my mind because I'm like, I need her to talk about the at-home pap smear.
Yeah, it's
And
incredible.
it's all over my feed. It's wonderful. And I think, I, thought about it when I first started practicing. I'm like, why can't we just wear a little tampon and send it away?
Yeah.
And
I've
here it
always
is,
said if I could do my own pap, I'd be happy.
Yeah, it's remarkable. I'm so grateful. All right.
Can I
We're
add
going to,
something? Can I
Yeah,
just say
sure.
something? We're
Please.
having a conversation. So the navigator, the patient navigator, came out of Harlem in the 1990s by a doctor who studied breast cancer rates and wanted to tackle why in the community Black women weren't getting mammograms. And of course, it was education, having access, and having a navigator, because even if there was a suspicious finding, there was no way to get an appointment. It was last. So that actually became the standard. And I always thought that was the marker that that's where that system came from in Harlem and dealing with Black women and dealing with, accelerating rates of breast cancer. So great work to hear it all coming
And
around
and
again.
yesterday I myself had a patient who she has everything at her fingertips, cell phone, car, community, couldn't get a breast surgeon, diagnosed with grade 3, could not get a breast surgeon, came in to see me for an annual exam just to try to get me to help her to navigate an appointment. I mean, the access to care is just very crucial and it's limited.
I see it all the time. It's heartbreaking.
It is heartbreaking, and I can't imagine. And just kindness. She was just taken back by my willingness to want to help her, and that right there was extremely humbling. We're going to touch on the next question, ladies. And this is a nurse leader and empowerment address. And I'm thinking in my head, so this is why I'm spacing out like who I'm going to start with. Nurse leaders are uniquely positioned to shape change across practice, research, and policy in women's health. Where do you see nurses having the most transformative impact right now, particularly in advancing equity and improving outcomes? And what needs to happen to further empower nurses to lead this work? And I think that I'm going to begin with Dr. Dorn. I think this is a good question for us to lead into our other panelists. Dr. Dorn, you're up next.
Well, it's baffling how we get not just a chair, but half the chairs around a table, to really have an impact on policy. And all of my work has led to the same, I can give you answers of why nurses say that they have to be in policy for pandemics, for women's health care, for chronic conditions. And it is such a struggle to break through the hierarchy of the healthcare system of doctors being on top of nurses, even though most of us are doctorate of nursing practice here. It's a continual struggle. And one of the strengths I get from working with WHO and working globally is to see how many people persist and how we can support each other to not give up. I mean, I thought a classic example of what are we doing was the COVID pandemic. And here you have the team reshaped here and in every country, right? Because everyone had to work at their full capacity. And there wasn't time to get doctors' orders to do something, right? And nurse practitioners stood up over and over again and had major roles in making decisions, which we always are supposed to have within our scope of practice. And nurses were saluted and applauded and cheered. And then the first health commission, when COVID was considered more in decline, presidential health commission did not include a nurse. And there was an uproar from all the nursing associations in this country, and a nurse was appointed immediately. But I've always thought, what happened? Yes, got answered, but we had to fight again and say, wait a second, and that was so true. The nurses in Liberia, who said, we were the last to know what was the reason, how Ebola was transmitted. But we were out there in the community giving care and dying without knowing how it was transmitted. So there's so many ways. I don't have a model, but we keep fighting to do it and fighting at every level that we can to do it, because we're the largest health counter in the world, nursing, right? And we understand what needs to be done in most situations. So that wasn't an answer so much as how we support each other doing this.
I think it's important to support each other. More importantly, when we're having to navigate an elitist title, But then that's going to get me into another topic. Let's talk about, Dr. Barcelona, tell me what your thoughts are with regards to nurse leaders and empowerment.
Yeah, thank you. So I really think we need more women in positions of power in this country. We need educated, smart women that are there for the populations that they are serving. And I think in many, if not most cases, nurses are there with that mindset of caring for people and populations, and that we're really well suited to serve in those roles. So, more research is needed in almost all aspects of women's health, and that's a policy decision. Other country level policy decisions, universal healthcare access, paid parental leave, systems and employee policies that support breastfeeding, and becoming politically active, whether that's voting, organizing in your local community, running for office. Like we know Lauren Underwood is
Yes.
a well-cited nurse who is a representative in the United States government, and more of us need to use our voices, I think, for the health and well-being of our communities.
Thank you for saying that. It's so true. And I'm so inspired when I have the ETP students that come from backgrounds of like education and now they're going into nursing to continue to move this project forward. Um, our next panelist is going to be Rebecca Schnall.
Okay. So thinking about nurses and where our opportunity is. So first, just acknowledging, right, nurses are the most trusted professionals in healthcare. And so I think that that is an opportunity that we can and should, and sometimes do remember to leverage. And I think this is particularly true in women's health, where the care is really deeply relational and really shaped by the social context. I see nurses driving impact in three critical ways. One is designing person-centered care models, which we've talked about earlier. Second is thinking and leading community-engaged research. And finally, translating evidence into practice, which I think we are trained to do so well and is so critical for us to do in the bedside and also in the community. But I think concurrently and really highlighting what my colleagues have said earlier is that we need to invest in leadership pathways for nurses, as well as research infrastructure. And then interdisciplinary training is essential for us, especially in areas like data science, artificial intelligence, and informatics. And so nurses cannot just simply adopt the emerging technologies, but we really need to be at the table as community partners, but also as leaders who are co-designing these tools. And so I think these three pieces all together, if we can mesh them, then I think that that really has the potential for us to see nurses as leaders and empowering us to lead healthcare.
Wow, that was very empowering. You're literally saying make space. And we have to teach our young ones to start making space for themselves. Like, excuse me, I'm here, make space. And I think that that's something that we need to teach nurses as they're leaving the programs is how to make space for themselves and elevate that voice so that they can have a seat at the table. Thank you. Molly, you're senior director of nursing, so I left this question last for you.
Oh God, it's such an interesting time. My hospital's on strike and has been, this is day 23. So, and this is my second strike that I've lived through with my hospital system. So it's a fascinating time, a very difficult time, but we have been preparing for this strike for probably 5 months. So
Wow.
that just tells you the extraordinary impact that nurses have on a hospital system and healthcare models that it takes an entire system to move quickly and efficiently and in a very organized manner to prepare for something like a nursing strike. Um, I think we have to hire our own. We have to promote from within. We have to train, we have to educate. I have a very smooth pipeline of hiring from Columbia School of Nursing. So if anybody's looking for a job, please reach out. But I believe, I believe that we all have to take care of the next behind us and advocate for those and help them navigate salary negotiations and teach the next generation. I think one of the greatest rewards in my work has been to hire a nurse who then finished her master's and became an NP that could then work with us and see her career goals achieved. So I think the role I see for leaders is very sort of hands-on within, on the ground. I think, building educational tools day in and day out within Epic is a great, very tangible remedy for some of the access issues that we face. And nurse leaders can do that, nurses, nurse practitioners, anyone can do that. But I think that helps us with the patient delivery issues. We can get information to them right away. They have live video libraries of data that they can review at home with their families. Financial navigation, advocacy, coordinating multidisciplinary care models. I think for me, it's very hands-on. I see my work day to day where I help one patient, but then I also help to create operations. So you actually touch many lives in that way. So I think everyone has to figure out the pathway for themselves and what leadership looks like. But I think there's a myriad of opportunities within nursing that we're all very well aware of, and it's represented by this panel here. And so you really can create your own pathway and whatever feeds you and whatever fuels you.
Thank you. I'm currently reading Brene Brown's book, Strong Ground, and it's a great book on leadership and being progressive and, finding different ways to navigate leadership and not being that rigid person, that, having that mindset that's flexible and is not a micromanager, but is allowing the visionaries and the implementers and managers to all shape their day so that we can all thrive and be successful. And it's such a great book. If I recommend it for anybody who's looking at a better way to lead. Um, Thank you. Thank you, everybody, for such insightful and beautiful feedback. So we're looking ahead. And as we look to the future, I'd like to know what gives you hope for women's health, and what do you want the next generation of nurses, clinicians, researchers to carry forward in this work? I think we've kind of touched base a tiny little bit here and there, but personally for me, I like it when I see my students being eager, wanting to ask lots of questions, wanting to get involved with patients, wanting to see the outcome. But as you all have different specialties, it's interesting to find out how this question will be answered. And we're going to begin with Veronica.
Thanks. So I think there's a lot of positives. I think there are a lot of wonderful nurse scientists out there that are doing impactful research that is positively influencing women's health and reducing health disparities. I also have a lot of hope in the new generation of nurses and nurse scientists that are coming up, that there's less acquiescence to the norm and the way things have always been done. People are questioning and they want to know, why are we doing it like this? And I think that's great, because I think that's what we need. We need to change paradigms where we can improve not only safe hospital conditions for women who are giving birth, but also for caregivers. We need to improve hospital working conditions, improve clinical education and training, so that we remove any perpetuation of racism or bias that's taught in nursing and medical education. We need to address trauma and moral injury and prevent and address burnout so that we can provide more patient-centered care, focusing more on midwifery models and wellness instead of disease or pregnancy as a disease. So I see a lot of things that, a lot of my colleagues at Columbia and across the country are doing. And I'm really heartened by the young new generation of nurses and nurse scientists.
Thank you, Dr. Barcelona. You mentioned on trauma, we talked about trauma, and I know that we're in this new era of wanting to promote longevity, especially in women's health. We're talking about IV drips and supplements and neurotoxins and all types of new age therapies, cold plunges, steam, right? But when you're looking at what's effective, we're really failing to address helping women deal with childhood trauma because that is one of the um, most important variables to promote longevity, right? So childhood trauma that's left untreated can lead to chronic disease, morbidity, mortality, and bringing more of a focus that you touched on. Thank you for saying that because I don't think we're giving childhood trauma the emphasis that it deserves, and it's something that we all can benefit from. Because there's another book I love reading. There's another book that was written by Oprah Winfrey. It's not what happened to you, but what happened. Um, what happened what happened to you. It's the title of the book, and I'm going to come back with that title. Um, but it's that essence of the product of childhood memories and awful things that can happen. Our next panelist is going to give us a little bit more feedback. Molly.
I have a lot of hope right now as there's so many conversations. The conversation is expanding everywhere you go. I was in India last March and two separate male tour guides, once they understood what I did, started to tell me about their wives bleeding and menopause. And so I think people are really talking about it and really curious. Hormone replacement therapy, weight management, sexual health, these are quality, survivorship concerns now that have become standard of care discussions. Informed shared decision making has also become the norm. The science is really remarkable. There are more treatment options than ever for cancer, and the ovarian cancer survival rates in the year 2000 were about 36%, and they're over 50% now. So we're giving patients better years and quality at that. But I think any advice that I would have for the next generation is to really keep the patient at the center of your care. The evidence really matters, but so does listening and being present and sitting quietly sometimes. Have the uncomfortable conversations, whether it's sexual health, menopause, end of life, palliative care. That's what really matters to your patients and their families, and they're going to trust you more than anybody, and they're going to want you present in those really hard moments. And that's really what has fed me in my career. Stay curious, not just about the science, but about people, and advocate relentlessly. Yeah.
Thank you, Molly. You touched on everything. And yes, Dr. Fraser, thank you for that. That was the name of the book. What happened to you? Such a great book. And again, that's another conversation to have. Dr. Dorn, what are your thoughts on looking ahead?
Well, I get real energy and hope from our students at Columbia University School of Nursing. I think we have um, really engaged, curious, motivated, committed students. And that certainly, if you're an educator, that's what you want, because you want people open to think of how this could be done differently, and how is it being done? How are we providing women's health care in different ways, or where is it working, or where could I get new ideas? And part of the real honor in the global of being the founder and working as a faculty liaison in the global student clinical program is how many people come to Columbia because they want to do global work, and they want to do global South work, and they want to be part of a larger nursing and midwifery profession. And Columbia University does provide that for them. And to watch what it means for people on the ground, especially midwifery students. There's always a lot of midwifery students, future midwifery students, who want to go global, and to watch them, what they take in. We're in a profession as a midwife, we're always involved in birth. And there's something, it's not equitable, and it's all the things that we've said before. But there is an amazing restoration by constantly being around birth and families. And every single family that I've ever worked with across this globe wants healthy baby and celebrates a new life coming into this world. And I'm just honored that I get to show some of that to students who come through here and who have been doing this for coming through for the last 12 years for this program. But that's where I get encouragement, because you really know they're thinking about where they're going to go and how are they going to do this. And that, that's what we build on here. And it's what an honor to get to usher in newer generations.
I agree. Thank you so much. And Dr. Schnall, let us know what your thoughts are.
So I think I have the hardest question now because Molly, Jennifer, and Veronica really did such a fabulous job thinking about what it is that we can do to look ahead. So I'll share some of my thoughts, but also really summarizing their very salient messages to all of us, which I think are really encouraging, especially as we're sitting in a time that sometimes for various reasons, whether it's nursing strikes, political climate, and just other challenges that happen in this world. And so I'm encouraged again by our students and the next generation of nurses. I think they're system thinkers, they're technologically fluent, and they are deeply committed to social responsibility. And so they don't say, should the healthcare system change, but they really ask, how can we change the healthcare system? And how can we contribute differently to the healthcare system as nurses than how nurses functioned in the past generations? And so I think that's very just empowering as an educator and a researcher to work in a climate with this next generation who are thinking about how they can challenge outdated models of care and then also remaining grounded in our core values of nursing, which are compassion, scientific rigor, and advocacy. And so I think that as we all go forward in each of our venues of women's health, if we really are thinking about health prevention, community partnership, and accessibility, I'm very encouraged and hopeful that the future of women's health will really be about enabling women to thrive across the lifespan.
I agree with your statements, and I'm grateful that 50% of America is in midlife, and I think that our voices are now getting very loud, and we want lots of answers, and we want implementation, and we want better care for our future generations. So I think we have also a country that's yearning for that. So we've covered research, care models, equity, and advocacy. I'd love to hear what resonated with you, and this is a question to the audience. I'm speaking to those attendees. Please put your questions in the chat. We have a couple minutes where we can engage with your questions and answering dependent on time. What questions or reflections would you add to the conversation? If you haven't had a chance, please put your questions in the feature now. I believe we've had some questions already as our audience puts in their questions. Let me go back to a couple of them that were in the chat. Let's see. Okay, Nancy Chase. Let's answer Nancy Chase's question. How can nurses play a more transformative role in public health? A major inspiration for me to choose nursing was the focus on prevention rather than the disease treatment model. So that's the question. How can we play a more transformative role? Dr. Schnall, you're here now. Let us know what your thoughts are.
Um, yeah, so, I think that nurses who work less by the bedside and more in the community, I think are playing a transformative role in public health. And so, um, again, when I think about the care and innovation that myself, Dr. Dorn, Dr. Barcelona, um, are providing really in the community. I think this is. And so I think some of it is just the pathways that we choose as nurses, and Molly, didn't mean to leave you out, but just a different within the clinical healthcare system, certainly critical to us, but less public health focused. And maybe that's the answer, right? Is thinking about when people have these events that take them into the acute care healthcare system. So I appreciate now that I left you out, Molly, because I think that's it, right? You don't know what you need until you don't have it anymore, right? And so we don't really understand our healthcare needs, our public health needs, until we're interfacing with what those challenges are. And so I think that it may be, right, thinking about when we're in these acute events, when we're in the clinical space, of how we better educate people to understand what some of these public health needs are.
Thank you for that. And I'm going to leave it open to another panelist to comment on that question. Jennifer?
Yes, I'm going to say something. I think also it's about Dr. Frazier's question, which is really how do we see the whole person? And I think this is the heart of nursing, is to see the whole person in the context of their family and their community, and to find time, no matter what you're doing, to make that connection. I mean, I had a real privilege. I chose it, but to be in a community for 20 years. So that became central to why women came in because there was time. I remember one opening the birthing center one morning at 7, and a woman raced in with this huge gash on her hand from opening a can and said, "You have to suture it." And I said, "Let's go across the community health center." They said, "You have to suture it. No one else is doing this." And I was like, well, I ended up doing it, but I didn't think it was the best job. But the point is the trust that we would be there. So, not everyone is going to work in a public health model, though I've argued here we need to keep trying to do that. There's always time to look at the whole person. And if you do that, the trust starts to get built, and people come to you with things that you would never imagine they are facing. But because they saw in you that you cared about them, you saw them. And no matter how many people you have to see in an hour and push for productivity, there's always time to see people. And I think that is the core of our values of being a nurse. And it's really a very precious thing that we have that ability in our hands. We have that education and clinical training to be able to do that. And then we just need to make sure everyone is seen as special because we all are unique.
Thank you. I have many questions, and I know that we're short on time, but I do want to address one question for somebody that I believe is young and is not a nurse. I'm not sure. Paris Wilson, I'm not sure if you can share with us your age. Maybe, I don't know if that's a personal thing. But I'm just thinking that maybe you're young because you say that in the comments. Um, so her question is this: what can I do to make, I figured you were 17, thank you. What can I do to make an impact on women's health now at such a young age? All right. Oh my gosh. So I'm going to leave this open to whoever wants to answer first, panelists. You can just unmute and just
I'll go. I think you're doing it, Paris Wilson. The fact that you're even here for this discussion means you're curious,
100%.
you're engaged, you're on your way. This is great.
Yes. You're interested. You're asking questions.
I would
Um,
say, if I
yeah.
could add, find trusted sources of people you know, nurses, physicians. It's hard to distinguish what is accurate health information in this day and age. So find the people like here at Columbia, find those who you know have accurate information and then share it in your community with your friends. Let people know you can be an agent for good public health and positive change. So thank you. I'm sure you're doing a great job as well.
Thank you for saying that. Thank you, Veronica. Um, you know, TikTok is the Bible nowadays, not trying to be funny, but everybody goes to TikTok for things and there's a load of misinformation. And our teenagers, our young people should be very well aware of what is real and what is not. Okay, does anybody want to respond to Paris? Otherwise, I'm going to head to one more question. Unsure if we have time or if you want to end here. Um, feel free to let me know if we're ready to end. So we're going to cut our discussion to 7 p.m. Ladies, I'm so sorry that we didn't get to the remainder of the questions, but we are going to respond to questions that we ran out of time for the sake of honoring everybody's evening and being respectful of your time and the fact that you're here. So I want to say thank you to our panelists for a rich and thoughtful and deep conversation. Thank you to you, our audience, for spending time with us tonight. These conversations matter and they shape how we care and how we teach and how we conduct research and how we advocate. Please remember that this is a series, and our next series is going to be on cardiac health, I believe. I have it in my notes. It is going to be March 4th, focus on cardiac health in person at Penn Club in Midtown. So if you want to just join us there, that'd be amazing. It will be moderated by Dr. Dean Frazier. We have another series in June, Nursing Workforce at Columbia Nursing. Join us on the terrace for that evening. It should be nice weather because it will be June. So we'll be in summertime, ladies. Have a wonderful evening. Thank you so much for being part of this community. And again, we will respond with answers to your questions. Thank you, everybody.
Thank you.